to talk about complications of bariatric endoscopy, and then it took quite a long time to prepare this presentation because I had nothing. But in the end, I succeeded, and I would like to present this to you. So what are we talking about? We know we have an increasing prevalence of obesity and also severe obesity in the Western world, and also metabolic co-diseases like type 2 diabetes or NASH patients in the Western world. And so we know we have different therapeutic approaches. We have the medical therapy, we have lifestyle modifications, and then we have bariatric surgery that has been proven to be very effective in control of obesity and also of the metabolic comorbidities. But only 1 to 2% of the patients can be treated surgically. And endoscopic bariatric procedures have been developed to fill this gap between the medical treatment and the surgical procedures. We know with the increase of efficacy of the procedures, especially surgery, also the risk of complication increases in surgical procedures. We have a risk of up to 30% of developing relevant adverse events during the course of the surgical procedure. So in 2015, the ASGE task force developed some criteria for developing endoscopic bariatric procedures. In terms of efficacy, treatment should be effective in reducing the excess weight loss of more than 25% in the 12-month follow-up, and especially the treatment should not be associated with an incidence of serious adverse events of more than 5%. We have different approaches that we can do as endoscopic treatment. We have, first of all, we have restrictive procedures, mainly targeted to the stomach, and all address the gastric volume to reduce gastric capacity, and this can be done by implantation of intragastric balloons and also by plication techniques that can be performed with the different types of suturing devices. And then we have, on the other hand, malabsorptive procedures, of which the main target is the small bowel. And there we have the sleeve technology, the duodenal sleeves or gastroduodenojejunal sleeves. Barrier is one of the most famous devices that can be used. And then we have ablation techniques like duodenal mucosal resurfacing. The Beyna balloon is the one that is most frequently used in the US and is also FDA approved because we have randomized controlled trials, sham-controlled, and then we know a lot of procedures have been performed since 2015. Recently we had this meta-analysis on 8 randomized controlled trials. As you can see, we have an effectiveness of 5.6% total body weight loss, but also in this meta-analysis we can see we have a relatively high rate of adverse events, up to 28%. Overall adverse event rate for the balloons, and also the FDA reported a safety update, and they reported that since 2006 the intragastric balloons has been associated with 33 deaths since 2006. Recently, we had the publication of this review of life-threatening complications of intragastric balloons has been published recently in Endoscopy International Open. And as you can see, 34 cases have been identified in literature dealing with life-threatening complications. 22 of them were gastric perforations, and remarkably 9 occurred in patients that had gastric surgery before. We had 2 cases of esophageal perforations that occurred, both in the procedure for implantation and removal of the balloon. And then we had 10 cases of bowel obstruction that occurred after unintended deflation of the balloon. All of them occurred in patients with with an indwell of the balloon longer than was usually planned before. So we had identification of possible risk factors of adverse events, serious adverse events in balloon. Intragastric balloons, patients with large hernias, patients with inflammatory bowel disease, patients with increased risk of GI bleeding, pregnancy, uncontrolled psychiatric disease, drug, alcohol abuse, and also previous bariatric or gastric surgery. And as a summary, we should keep in mind partial gastrectomy should be an absolute contraindication for implanting an intragastric balloon because of the high risk of perforation in the course of the treatment. The next procedure would then be malabsorptive technique. We have the endobarrier, a duodenal jejunal biplus sleeve. We all know it, the system comprises of a 62 centimeter long sleeve, we have here this proximal part that is implanted into the duodenal bulb. And then the sleeve prevents of the food coming into contact with the bile and pancreatic juice. And we know also from recent meta-analysis, this technique is quite effective. We can see significant reduction of total body weight loss and excess weight loss, and also control of the metabolic comorbidities. But then we should have a further look at the adverse events. So Georg Kehler gave this slide to me, and it's very instructive, I think. So this is what the patients see when you talk to them, talking about the implantation. And on this picture, you see what the device is really looking like. So you have this sharp barbs that are located on the outside of the device. And if you implant this device to the duodenal bulb, there's the potential effect of causing some adverse events here. And this was also addressed in this aforementioned meta-analysis. As you can see, there was an overall rate of serious adverse events of 15.7%. That's relatively high, and this rate comprises of every kind of thing. We have a high rate of bleeding, we have acute pancreatitis, and then we also have sleeve migration and a rate of liver abscess in this meta-analysis, 1.1%. Also pain, and we have ankle perforation. I will show you a slide of this in a few seconds. So a relatively high rate of serious adverse events in the biplus sleeve, and from a recent publication I have these two images by Demura recently published, and you can see what can happen. This is one of these sharp barbs that is located on the outside of the device, and what happened here is that this barb perforated from the duodenal bulb through the pylorus into the stomach. And you can see some tissue ingrowth into the bypass liner here, and then it's relatively complicated to remove this device endoscopically. But finally, this was successful, but this needs some very good experience. And finally, to mention, we had this US randomized controlled trial, endo trial on endobarrier, quite effective, but then the trial was stopped by the Data Safety and Monitoring Board because of this very high rate of 3.5% of all the cases developing liver abscess in the course of the treatment. Keep in mind, in the meta-analysis, there was 1.1%, but in this randomized controlled multi-center trial, 3.5%, and then the trial was stopped, and since then it's relatively quiet in terms of further clinical evaluation. Finally, we come to the next endoscopic procedure, endoscopic sleeve gastroplasty. So this is a procedure that can be performed by endoscopic suturing procedures, and always keep in mind, endoscopic sleeve gastroplasty is a plication technique, a non-resective technique. So endoscopic sleeve gastroplasty is not the same as a laparoscopic sleeve gastrectomy. So you don't have this suture line, no stapling line on the. You don't resect part of the stomach. What means the rate of insufficiency of leakage should be less compared to the surgical procedure. And I would like to show you the data in the next slides. Principle of the treatment is that you reduce the gastric volume. It's a restrictive technique. And on the other hand, normally you do the plication starting from the incisura to the proximal body and leave the fundus of the stomach open. So you have a reservoir in the fundus, and you also delay the gastric emptying. You can see this in this fluoro image, and you also in this image of a delay in gastric emptying scintigraphy. So a short video for all the ones that don't know the procedure. So you start at the level of the incisura, and then you can apply these sutures. Usually you start with 6 sutures that approximate the anterior wall, the major curvature, and the posterior wall. And this, in this case, is done with the Apollo overstitch system, a device that is in this case adapted to a double-channel therapeutic endoscope. This suturing device, and to apply this full thickness sutures, you can use this tissue helix, and this is drilled into the wall of the stomach and pulled into the device, and then the suture is applied and then released. So you're doing really full thickness bites here, usually 6, and then the suture is approximated by putting in a cinch to close the suture. Then you apply 3, 4, or up to 5 sutures, and then you have the procedure done. So how effective is the therapy? We have, again, luckily, a meta-analysis of more than 1,700 procedures. And if, as you can see, in short and midterm follow-up, this seems to be very effective in the decrease of total body weight, and also excess weight loss of 57.7%. And as you can also see, we have a pooled rate of adverse events, of serious adverse events, of 2.2% for this procedure, mainly pain and nausea, but also some bleeding, and with 0.48% perigastric leakage and fluid collections. So we will have a further look at this point. We have another meta-analysis, because I previously mentioned that the procedure can not only be done by the Apollo system, but also by different techniques. The POST technique is another technical device that can be used for gastric plication. In this meta-analysis, both techniques were included in the meta-analysis, and as you can see, the endoscopic sleeve gastroplasty was more effective using the Apollo device, and it could not be a significant difference in major adverse event rate could not be found, about 1% for both procedures. So let's have a further look on the complications that can occur. Recently, there was this publication of a gastric perforation that occurred some days after endoscopic sleeve gastroplasty. I only have this image from the publication. As you can see, here's the large defect and passes outside the stomach. So this patient had to be treated surgically because this was recognized a little bit too late, some days after the procedure. And we had also this publication, also recently published in GI Endoscopy, about perigastric abscess and collections as in delayed adverse events in endoscopic sleeve gastroplasty. And the reason for this is that you apply a full thickness suturing of the stomach. So you, as I've showed you before, with the helix you get the whole wall of the stomach, and then you can penetrate with the needle to the outside of the stomach, to the serosa, and so bacteria can invade alongside the suture and form some fluid collection, and then also some infected perigastric collections that can usually be treated as we are used to treat pancreatic collections or pancreatic necrosis in the course of the procedure. But you have to keep in mind that this can happen. There's also the reason why it is recommended to use antibiotic prophylaxis in these patients to prevent superinfection of the collections. And this image I have from my friend Ivo Boskowski from Rome. He does a lot of these procedures, and this is the laparoscopic image of the stomach during sleeve gastroplasty. And in the center you can see this, and this is the helix of the helix catheter from the outside after 3 turns of the helix wheel. So you drill into the wall of the stomach, and this is the helix in the abdominal cavity. So you can imagine what happens. Sometimes you should take care of not touching some organs that are outside the stomach. And we had recently another publication, also gastrointestinal endoscopy, recently published by Lopez Nava, who is one of the most experienced users of the system for sleeve gastroplasty. And the patient developed a biliary peritonitis, and this video is from the publication. So you can see this is the stomach with an approximation of the anterior and posterior wall, and you can see another structure here that is caught into in this suture. So this was a gallbladder that obviously has been caught by the helix and was sutured into this gastric placation, and so there was a bile leakage that was developed, and this could only be treated surgically. But this is a very rare event. But always keep in mind that you do full thickness suturing, and you drill the helix to the outside of the stomach to achieve full thickness suturing. If we compare sleeve gastroplasty to laparoscopic sleeve gastrectomy, we have no prospective comparative data. We have retrospective match control study, also recently published, comparing both procedures. As you can see, laparoscopy is more effective in terms of weight loss, but on the other hand, endoscopic sleeve gastroplasty has significant less adverse events. Overall, 16.9 compared to 5.2%, and remarkably, also one thing that can occur after sleeve gastrectomy. 14.5% develop a new onset of erosive of GERD disease, and only 1.9% in the ESG group. But this is only a retrospective study. I would like to sum up. Endoscopic, bariatric, and metabolic therapy is promising to fill the therapeutic gap between lifestyle modification, medical treatment, and surgical bariatric surgery. Intragastric balloons have limited efficacy. We have frequent adverse events, but severe complications are rare. The endobarrier duodenal bypass sleeve, we also have limited effectiveness. We have frequent adverse events, also serious adverse events, and we still have the long-term results are still unclear. And in terms of endoscopic sleeve gastroplasty, gastric placation, the technique seems to be less technically demanding. We have a better adverse event profile, also to compare to laparoscopy. It seems to be effective in achieving clinical relevant long-term weight loss and also improvement of the metabolic comorbidities, but still we have no comparative prospective trials comparing to surgical procedures. Thank you very much for your kind attention.
Yeah, thank you, Dr. Beyna, for the interesting talk. Are there any questions? So maybe I can start. So in terms of safety and efficacy, I mean, I understand endoscopic weight loss procedures fill the gap between more conservative measures and surgery, but what is the ideal, what drives patient selection? What is the ideal patient for an endoscopic procedure, and how do you then decide which procedure to recommend?
It's a very good question. The exact indication is probably still to be defined, but at the moment it seems to be effective for the patients that are not the super obese patients, for example, that cannot undergo surgical procedures right now. So we can do endoscopic sleeve gastroplasty in the first step, and then after some weight loss, the patients can go to definite surgery. They should go there. And on the other hand, we could treat patients with mild obesity with also to treat the metabolic comorbidities like type 2 diabetes and so on. So there's a lot of room for endoscopic procedures in the future, I think.
Just two issues. The first thing is from the surgical experience, sutures that are mostly adapting the mucosa do not hold so long, and the stomach has a very propulsive peristalsis. It moves all the time, so the sutures probably will come out. And also I saw that there are not real long-term data available, mostly 2 years follow-up.
Yeah. That's correct. So we need long-term data, we need comparative data, but on the other hand, the issue with the sutures could also be an advantage for the patient, because there's the potential that this technique is reversible. So we don't have definite resection during the because we adapt mucosa to mucosa. During the first weeks, months, these sutures can also be reopened. So because we don't have a gastrectomy, and we could also repeat in cases with if the patients gain weight again or something like that, we could repeat, and we could also apply these therapies to address complications that can occur after surgery. If we have dilation of the anastomosis after gastric bypass, for example, we can reduce the orifice. So, but it's all maybe it's a good thing to fill the gap between all techniques.